Thank you, Mark, and thank you for the organizers for inviting me to talk today. The only change that I made, Mark, was to screen or not to screen, as opposed to consult or not to consult. I have no disclosures, except I would like to share with you guys the story of these guidelines. A few months ago, somebody smart came up with an idea, and the idea was, Ashraf, Sarah, and Michelle, you guys would like you to talk about the new cholesterol guidelines. Now, Mark was referring to these guidelines that were published in print in December of 2010-11. Now, the date here is very important. November 14, 2010-11, at the American Heart Association, the release of these guidelines was made. On the same day, if you have done a Google search like I did, you will find the following descriptions for these new guidelines that Mark wants us to talk about. The first thing is irrational. There will be a lot of temptation to use medications in this population. And there is an absence of evidence supporting pharmacological intervention. And the last part that I really like is this one. Of course, you don't need a blood test to tell a child who's obese that he needs to lose some weight. So, in addition to this, there was more controversy in the medical literature. JAMA, in December of 2010-11, exactly a month after the online release of the new guidelines, two physicians, in an argument, in a viewpoint, argued that universal screening and drug treatment in children with dyslipidemia is not justified. A month later, now we are in January of 2010-12, Dr. Gilman and Dr. Daniels tried to defend the viewpoint of the guidelines writers. To answer the question of, is universal pediatric lipid screening justified, Dr. Daniels answered yes, Dr. Gilman answered no. Now this gets more exciting once you realize that Dr. Daniels was the chair of the committee that wrote the guidelines, and Dr. Gilman was a member of that committee that wrote the original guidelines. This continued last month. The leaders of the original group came up with a publication in Pediatrics trying to explain how did the guidelines get generated, what do they mean, and how did they come up with their conclusion. So, Mark, I think this is what you meant when you asked us to give the presentation. That being said, let's go over these guidelines and see how they are important to me and you, and how can we help children with dyslipidemia. What I would like to cover today is, number one, the first question is, who should be screened? When should we use selective screening versus universal screening? We will talk about different patterns of hyperlipidemia that we can see in children, identify the lifestyle modification that is used in the treatment of such children, and finally appreciate when to refer a child with dyslipidemia to a preventive cardiologist. At Children's National Medical Center, Heart Institute, we see around 16,600 new encounters a year. As you can see, the most common diagnosis that we take care of is congenital heart disease. Hyperlipidemia is seen in our institute in around 400 patients a year. This does not include the Obesity Institute, our GI colleagues, and many others in children that do take care of such patients. We know in the adult literature that hyperlipidemia is associated with atherosclerosis. This has not been well established in the pediatric population. We do rely on a couple of information that we have in children. Number one, the homozygous familial hypercholesterolemia, the very rare disorder that can happen in 1 in 1 million children with lipids more than 1,000. Those children are at risk of developing cardiovascular disease as early as teenage period. We also have evidence of subclinical atherosclerosis seen in children, manifested by non-invasive images. When an injury happens to the blood vessel, in the normal situation, when you have a normal environment, healing occurs completely and the blood vessel goes back to the normal. In the presence of aging, high blood pressure, smoking, obesity, inflammation, insulin resistance, this healing process goes away, and as such, atherosclerosis and plaque formation occur. This is one of the very rare papers that try to look at the answer of, does hyperlipidemia in young children and young adulthood predict atherosclerosis or cardiovascular disease in adults? This was published in 1993. Dr. Clegg was an internist at Johns Hopkins University back in the 50s. Part of her gifts to her graduating medical students was a blood draw that they had to do before they got their certificate. Dr. Clegg continued to follow up her students throughout their career. When you read this article that was published in the New England Journal of Medicine, it correctly states that IRB and consent did not exist back in the days when this study was done. As you can see, the higher your cholesterol when you graduate medical school, the higher the incidence of cardiovascular disease 4 years later. We do have factors that can lead or can accentuate atherosclerosis, dyslipidemia, high blood pressure, obesity, smoking, physical inactivity. There are certain diseases that can also increase your risk for cardiovascular disease. Diabetes, chronic kidney disease, children with transplantation, Kawasaki disease, especially those who had aneurysmal formation, survivors of childhood cancer, and nowadays adults with congenital heart disease. We do have published tables with normal values. Ideally, we would love the total cholesterol to be less than 170 milligram per deciliter, the HDL more than 45 milligram per deciliter, LDL less than 110 milligram per deciliter. So the first question is, who should be screened? Now, this is not new. This is what was published back in 2008. This is what the selective screening had asked for. Children 2 years and older with either a positive history of premature cardiovascular disease in a male relative less than 55 years of age, female relative less than 65 years of age, or a child who has any condition that I mentioned previously, obesity, high blood pressure, hypertension, or any other risk factor for cardiovascular disease. And finally, if either one of the parents have an elevated lipid more than 240 milligram per deciliter. This is selective screening, and this has not changed. We go to Bill Neal from West Virginia and his practice with universal screening. In West Virginia, it is the practice to screen all children at the 5th grade level. And what I want to highlight to you here is a couple of things. The first one, we learned from Bill, is that 71% of children in the 5th grade will qualify for selective screening. So when we talk about selective versus universal, we are talking about increasing the children who will be tested from 70% up to 100%. So let's take this away and look at those who did not meet the criteria for selective screening. For those children who did not meet criteria for selective screening, 10% of them had an elevated LDL more than 130 milligram per deciliter. And this gets even more exciting when you realize that that child could serve as an index, because many of the patterns that we see are inherited in an autosomal dominant fashion. So you could help that child's parents by recognizing that they do have a disorder that they were not familiar with. And as such, they can get screened and get better therapy. Also, of those children with an elevated LDL more than 160, 1/3 of them failed the selective screening. The other part is the age at which we do screening. So this came from the NHANES survey. The data was until 2004. This was published in 2009. There is a normal, usual tendency for the cholesterol to drop through puberty. And this is seen across the country. And this is why the new recommendation for universal screening suggested the age of 9 to 11, which is a prepubertal, and then once you are done with the puberty, 17 to 21 years of age. Now, the second question is, what kind of screening should we do, fasting versus non-fasting? And there are recent reports that had looked at the effect of fasting on the lipid profile. So for the total cholesterol, for most of the part, the fasting doesn't really affect the numbers by much. So if you have a child with a total cholesterol of 240, asking whether it is fasting or non-fasting really won't make a big difference on that child's risk for cardiovascular disease in the future. We also see the same phenomena for the HDL and the non-HDL. Now remember, total cholesterol and HDL are measured in the lab, whereas most of the others are calculated. Non-HDL is the subtraction of HDL minus the total cholesterol minus HDL. So this is what we will be relying on in our universal screening. The major effect of fasting is on the triglycerides, as you can see on this diagram. This is the equation for you to remember how to calculate the non-HDL. Some labs now do give you the non-HDL on the profile when you request it. If you find an abnormal value, the recommendation is to repeat it to confirm with fasting profile. There are many patterns of hyperlipidemia, and I would like to share with you two of them. First one is a 14-year-old boy referred because of hypercholesterolemia. His father died in his 60s with a coronary artery disease. This is a child whose father started having problems with coronary artery disease in his 40s. The profile, as you can see, showed an elevated total cholesterol, more than what we would like it to be. The LDL is way high at 226, and nicely the triglycerides are in the normal range. This is a patient with what we call familial heterozygous hypercholesterolemia. It's an autosomal dominant, so either one or two of the parents will have the same kind of pattern. It affects 1 in 500 kids here in the States. In some populations, it is as common as 1 in 100. Untreated, and by the age of 50, 50% of men will develop cardiovascular disease, 25% of ladies will develop cardiovascular disease. Now, the question now is, how do you treat such patients, and how do you counsel them? The first line of therapy is the therapeutic lifestyle modification, which I will spend a lot of time on, which serves as a second line of therapy and our third line of therapy. The goal today is to familiarize you with therapeutic lifestyle modification. If that's the one take-home message that you'll take, I'll be very happy camper. So what we mean by therapeutic lifestyle modification is a healthy, heart-healthy nutrition, exercise. We want them to deal with the stress, and we don't want them to be exposed to smoking, passive or active. I want to familiarize you with the Harvard plate, Harvard Healthy Eating plate. And I want to start with this corner up here. We want to encourage the healthy oils. We want them to encourage eating and using olive oil or canola oil as opposed to the other forms of fat. We want them to eat more of the vegetables, but at the same time, we want to make sure that they know that French fries and potatoes are not considered a good vegetable. We want them to eat a variety of fruit. Let me jump up here. We want them to eat more of the whole grain products. We want to encourage water. Water is our friend. And we want them to eat more of fish and chicken as opposed to the other types of meat. And what you can see here is stay active, and we want to talk more about being active. So in other words, we want to upgrade their fats, basically eliminate the trans fat in their diet, lose less saturated fat. We want to get rid of their sugar-sweetened beverages. We want them to rely more on the whole vegetables and fruits. And we want to increase whole grains, again, more for fish and chicken and plant protein. Unfortunately, although that's what we advocate for, this is what our children are eating nowadays. We want to try to minimize these components. A question keeps rising every now and then. I do get emails from different pediatricians about the safety of limiting the fat in the diet in children and in infants. This is a paper that looked at limiting the cholesterol as young as 7 months of age. So children at 7 months of age were randomized into two groups. One had the standard way of care, and the second one were exposed to low saturated fat. They received continuing counseling from a dietitian. They were followed until 14 years of age. And not so surprisingly, those with the intervention had lower serum total cholesterol as well as LDL. But I think the more important part was this here. There was no difference in the two groups when it came to growth, development, age of menarche for female. This is one of the reasons why the American Academy of Pediatrics came up with a recommendation a few years ago that children as young as 12 months of age can receive low dairy products if they are at risk of developing cardiovascular disease. Some options for healthy fats that I would leave for you guys to take home with, and some of the options for the unhealthy fat, and this is from Michelle, absolutely no trans fats. Some examples of the simple carbohydrate and the complex carbohydrates. And we want to be active. We want to do more activity. We want to limit the amount of TV, monitor, videos to maximum of 2 hours per day. We want to get rid of these machines from their bedrooms, and we want them to be doing moderate to vigorous activity on a daily basis. This has been associated with improved waist circumference, blood pressure, triglyceride, HDL, and insulin sensitivity. Just another word, more like data on the effect of activity. Children, one measure for, or one non-invasive measure for cardiovascular risk is arterial stiffness. And the way that we do that is by looking at the flow-mediated dilation. The more stiff you are, the less dilation we will see. And in this diagram, you can see that children who were active had much better flow dilation, much less arterial stiffness, in theory, lower risk for cardiovascular disease in the future. And there is an equation that correlates how much active we are with how much an improvement of our arterial wall we will have. Next time you meet with your child and you start talking and remembering this talk about therapeutic lifestyle modification, I want you and that child to come up with the 3 specific goals that will be measured the next time you see that patient. These goals, I would encourage you to have that child himself come up with. At Children's, when you send a patient to us, they meet with preventive cardiologist, myself, Michelle or Sarah, a dietitian, and one of our nurses, and we talk and talk. At the end of it, they might not grasp on 1 or 2 things that they can go home with because of all of the information that we are providing them with. It will be a good habit for us and for you to come up with the 3 specific goals. For example, packing school for lunch, going the activity, having a fruit for a snack, something like that. And you want to encourage them, their activity. And the last part here, and I know that at Children's we struggle with this one, meeting with a nutritionist 3 different times consecutively has been associated with an improvement of compliance a year later. We struggle with having the nutritionist see the children that frequent. The second pattern is this one, where the triglycerides are very high, 615. Many times the lab will not give you the results of the LDL because of the high level triglycerides. Those children are at risk of pancreatitis earlier than they will develop cardiovascular disease. The treatment is therapeutic lifestyle modification. We want to encourage more complex carbohydrate. There are very rare disorders in which there is a total lipoprotein lipase deficiency. We do have a child at Children's who, at 3 months of age, a blood draw revealed totally white color, and the triglycerides were 30,000. This is a very rare disorder. The therapy is fat restriction, and those kids are at increased risk of recurrent pancreatitis. We want the family to be involved. We want them to be active. We want them not to skip meals. Children are different, families are different. Some of them, this might not be a good idea for. So it depends on where your child is coming from. If the diet is using a lot of soda, then these options might be good for that particular child. We want families to be positive role models. We want them to be involved in their school board. We want them to visit local farmers market and get involved with healthy food habits. I want to share with you the story with this 23-month-old girl who was referred by a dermatologist. She had this rash. Now the rash, I couldn't make it. It's actually palpable. She had it all over her body. This is on her elbow, and this is down at her ankle. This is a child who was seen starting at 9 months of age. She started having this rash and was managed conservatively with, let's see what happens next month. Eventually, a dermatologist looked at this and obtained a cholesterol profile. So her total cholesterol, as you can see, is way too high, 832 milligram per deciliter. LDL is also very high. So when this child came to Children's, our first thing was call a friend. So we did. And then we contacted our preventive cardiology association named Pediatric Atherosclerosis Prevention and Lipidology Group, which I will hope that you will be hearing more about in the near future. This is a group of pediatric preventive cardiologists It used to be the East Coast, but now we are invading the Midwest, and we're going beyond that. They are charged with improving the well-being of children and improving the research around pediatric dyslipidemia. So we contacted them by email. The first person was Ray Cavey, more of them, and then we came up with a plan. And the plan was, in addition to lifestyle modification, to use a very low dose of lipid-lowering agent. She had a dramatic response to the therapy, and her rash, as I will show you, had decreased. And nowadays it's more like a pigmentation. We're still working her diagnosis. LDL sequencing is being processed. She most likely has a form of hypercholesterolemia. Her response doubts against the homozygous pattern. So in summary, I shared with you that 1 in 500 children will have a familial heterozygous hypercholesterolemia. So how does this relate to your practice? The reality of things is that you are seeing more of those children. 40 to 50% of them will have some sort of dyslipidemia. The CDC recently released that 20% of children 12 to 19 years of age will have an abnormal lipid. If you look at your obese children, 40 to 50% of them will have a form of dyslipidemia. For those of you who are scared of medications, I want to share with you what the current practice is. Although 6% of children had an elevated LDL between 1999 till 2006, only 1% would require pharmacological intervention based on the new guidelines. It's very rare for us to start medical therapy. We always do lifestyle modification, some of us 6 months, some of us 1 year, and we only resort to lipid-lowering agent if we have to. So let's go back to the controversy and where do we go from here. And what I want to share with you is the power of the lifestyle modification. This is a paper from, it's the Cardia paper. It's a famous paper in the adult literature. And what they did is they looked at those following 5 healthy lifestyle factors. They looked at the healthy lifestyle factors are, number 1, a body mass index less than 25, having little amount of alcohol, being healthy with their diet, and being more active, and no smoke exposure. They looked at adults in their early 20 to 25 years of age, and then they followed them up 0, 7, and 20 years of age. And this is what they found. The healthier you are, so the more healthy factors you have in your life, the chances that you will have a low cardiovascular risk 20 years later will be higher. Now, as you can see, it is not 100% because there are other factors. Genetics is a major one. But the healthier you are, the better it will be 20 years later. Now, this diagram here from another paper in JAMA early this year looked at the effect of having optimal risk factors, so having the best lifestyle and the risk for cardiovascular disease in the future. I just would like to see in this audience who would rather not be in the green line. Okay, good. So this is the power of the lifestyle modification. And let me jump into this. And I really like this table because it actually summarizes the power of the lifestyle modification. What they looked at is they looked at those who had more than 4 of the factors that we identified. If you never had a good, healthy lifestyle, your chances of having a low profile is going to be very low. On the other hand, and not so surprising, if you have always been healthy, your chances of having low cardiovascular risk later in life will be high. Now, again, it's not 100% because there are many other factors that contribute to this. Now, where you guys come in is if you see a child who's not following a healthy lifestyle modification, encouraging them to develop a healthier lifestyle will be associated with an improvement. The improvement will be sustained the longer that they will do it for. And then this is the best part that I would like to share with you. The healthier lifestyle developed after you see that child, if it's maintained, the risk for a low profile is as near as those who came to your office with healthy from the get-go. So I would agree with Dr. Daniels that by the time that you reach 45 years of age, if you had no risk factors, you have a much better life expectancy, and it is our job, parents, pediatricians, pediatric cardiologists, to deliver healthy, normal children into their adulthood with the least risk. So the next time you see a child with, who meets the criteria for non-fasting profile, we would encourage you to follow this recommendation. If the non-HDL is less than 120, repeat profile, 17 to 20 years of age will be recommended. For the borderline patient, what I would like you to do is go back and talk to that family and see if there is any other risk factors that were not mentioned before you identified the lipid number. If there are no other risk factors, we will encourage lifestyle modification, repeat the numbers to encourage the family to adhere to the lifestyle modification. If they end up having risk factors, we would confirm the profile on 2 different occasions, a few months apart, and then lifestyle modification. We do have a threshold above which we would be happy to see those children. I know some in the audience and some pediatricians are comfortable managing hyperlipidemia and starting lipid-lowering agent if they have to. You don't have to send them to us, but we will be happy to see them if you would like us to see them with these values. On the other hand, non-HDL more than 145 calls for confirmation and for more intervention. I do have laminated handouts of this to keep in your office for those of you interested. It will be located outside on the table. Remember, there are other disorders that can lead to dyslipidemia. So the moment that you identify a child with hyperlipidemia, you want to make sure that they don't have thyroid problems, chronic renal failure, nephrotic syndrome, liver failure, drugs, and this includes protease inhibitors. And today, you guys learned that thiazide can be associated with hypercholesterolemia, so I will add that. These are the labs that we will obtain to rule out secondary causes and to help us guide the management. Again, our number is 202-476-4809. We will be more than happy to have a phone conversation or discussion if you have a child that needs intervention. For those who are obese, hypertensive, don't meet criteria for dyslipidemia, our colleagues in the Ideal Clinic and Obesity Institute will be happy to see them. We do have a new revamped website, Children's National Preventive Cardiology Program. We have resources for you, for the families, and referral guidelines. We also, I want to mention the government here, choosemyplate.gov is a very nice website that you could also refer your patients to. We do have an email, preventive@childrensnational.org. The email is staffed by Dr. Michelle Maeta-Snyder, Sarah Klaas, and myself. Our dietitian is Amy Randall. Renata is the triage nurse. Kristen and Monk are our nurses. Thank you for your attention, and I'll be happy to take questions.